Thank you for joining us for today's AANP Teaching Rounds presentation. We'd like to begin with a few notes. By default, participants' video is turned off and all participants are muted. We ask that you keep your video off and remain muted for the duration of the presentation. We will turn participants' video off to minimize distractions. We will have Q&A at the end. If you have any technical difficulties, please message the Zoom meeting host. We would like to inform you that this session will be recorded. Today's session is accredited for CME credit. All accredited CE information may be found in PathLMS. I will now turn it over to Dr. Oviedo to provide a brief introduction of today's speaker.
Good morning, everybody. Natalie Wolkow, MD, PhD, is an assistant professor of ophthalmology at Mass Eye and Ear Harvard Medical School with subspecialty fellowship training in ophthalmic pathology and ophthalmic plastic and reconstructive surgery. She completed undergraduate studies at Georgetown University and then medical school and graduate studies at the Perelman School of Medicine of the University of Pennsylvania. This was followed by ophthalmology residency at Mass Eye and Ear Harvard, and then 2 fellowships, the first in ophthalmic pathology and the second in ophthalmic plastic and reconstructive surgery, also at Mass Eye and Ear. Her current practice is split between ophthalmic plastic surgery and ophthalmic pathology. In her clinical practice, she sees patients with a variety of eyelid and orbital conditions. Her current research interest is in orbital and periocular malignancies, with a particular focus on advanced conjunctival and periocular cutaneous squamous cell carcinomas. Given her practice, she also has unique expertise in post-surgical histopathologic alterations after ophthalmic surgical procedures and enjoys reviewing them with trainees. And I'm really looking forward to this presentation.
Okay, well, thank you very much for that introduction, and it's lovely to be joining all of you today. I was asked to give a talk about what do neuropathologists need to know about ophthalmology, and the answer is there's a tremendous amount. I'm hoping to touch on some of the things today, but certainly I won't be able to cover everything. I have no disclosures. And so today I'd like to take a case-based kind of approach, as I was asked to do. And as part of those cases, I'd like to review with you some of the normal orbital anatomy and histology. We also will cover and touch upon some common ophthalmic surgical procedures that are relevant for pathology. And then also we will touch upon some diagnoses that are unique to the ocular region as well. Just to give you a brief sense and an overview, for eye pathology, we are not focusing on just the eyeball, but also on everything else that's in the orbit. So our specimens come from the eye socket, which includes muscle, fat, periosteum, soft tissue specimens of different kinds. It has the lacrimal gland there as well. We also get many things from the eyelids. And then we get, of course, tremendous number of specimens from the ocular surface. And so in eye pathology, I'd say that most of our specimens will come from the oculoplastics service, some from the cornea service, and then some from the retina service as well. But it is a big mixture of things that is not confined just to eyeballs. The other thing is there's also the lacrimal system, so sometimes things will also spill over into the area of the sinuses as well. So let's jump right into cases because I don't want to waste too much time. So the first case we'll start with is some corneal tissue that was submitted for evaluation. Before we look at the actual case, I wanted to review some normal corneal histology with you. So the cornea, as you may recall, is the front part of the eyeball. It's clear and allows light to go through and helps with refracting and focusing light. And it is composed of an epithelium on the surface. You have these basal epithelial cells, then wing cells above them, and then a layer of more flat squamous cells on top. Below the epithelium is Bowman's layer. Bowman's layer is not a membrane, but it's actually just a slightly different organization of the fibers than the corneal stroma that's below it. You have the corneal stroma. Histopathologically, normal corneal stroma does tend to have this little bit of this clefting artifact, and that's normal. And then after that, you have Descemet's membrane, and then corneal endothelial cells. The corneal endothelial cells are very important for sucking fluid out of the cornea to keep it nice and compact and prevent corneal edema. You only get a certain number of corneal endothelial cells that you're born with, and they do tend to decrease in number over time. Surgical procedures can also make their numbers go down. And so really important for those endothelial cells to be preserved to maintain a nice and healthy cornea. So let's hop on back to our case over here. What you can see is that we have corneal epithelium on the surface. There's also Bowman's layer underneath it. And then after that, you have corneal stroma. But here there are many empty spaces scattered throughout the corneal stroma. And as we look a bit closer, there are also deposits that are scattered throughout the corneal stroma. Looking further down, it's hard to appreciate any Descemet's membrane or endothelial cells. So we have a periodic acid shift stain here. Periodic acid shift is often very useful in highlighting Descemet's membrane in corneal specimens. And here this confirms really no Descemet's membrane or endothelium in this specimen. Now, ophthalmology residents learn about corneal stromal deposits. And whenever you see corneal stromal deposits, you think about corneal stromal dystrophies. And all ophthalmology residents will learn this mnemonic about corneal stromal dystrophies. Marilyn Monroe always gets her man in LA County. That really reminds us of the main corneal dystrophies. And so the first one is macular dystrophy, which is composed of mucopolysaccharide deposits. And those stain positively with Alcian blue, although some will use colloidal iron. Granular dystrophy is the next one, and that is composed of hyaline deposits that we will detect with Meson trichrome stain, and then lattice dystrophy, which is usually composed of amyloid and will be highlighted with Congo red. So those are the main corneal dystrophies that we think about. Certainly there are many others. So let's go back to our specimen where there were some deposits in the cornea. Here, this was a colloidal iron stain that was done rather than an Alcian blue. You can see that there are areas of little blue background staining, but the deposits themselves are negative with colloidal iron, really suggesting that this is not macular dystrophy. Now, moving on, we have a Meson trichrome stain. Here, the deposits actually stain bright red, which would suggest granular dystrophy. Again, bright red deposits in the corneal stroma. But let's take a look over here. Here is Congo red. And so these deposits are also staining with Congo red, which you'd expect in lattice dystrophy. And you can see that there is some apple green birefringence. Here's another area with Congo red positive deposits. And you can see, again, there are areas where there's apple green birefringence. So that suggests more lattice dystrophy. So what's going on here? Our stains don't really line up. We're basically aligned with both granular dystrophy and lattice dystrophy. So let's think about that. There's actually an explanation for that. As I said, there are actually many corneal dystrophies. Corneal stromal dystrophies, they are autosomal dominant, and many of them are caused by mutations in the TGF beta I gene. Although it's the same gene, there are different mutations that end up causing different clinical and also histopathologic appearances. The classic lattice corneal dystrophy has these type of lines in the cornea, and these are amyloid lines. The classic or granular type dystrophy 1 has this crumb-like appearance, and these are hyaline. But there's also a granular dystrophy type 2 called avelino dystrophy. This is a slightly different mutation in the same gene. And what ends up happening is that avolino-dystrophy combines the features of both granular type 1 and lattice type 1 dystrophies, both clinically and histopathologically. So clinically, you will get an appearance, some star shapes. Sometimes you'll have both lines and crumbs. And histopathologically, you will have both hyaline and amyloid deposits, so both positive for trichrome and Congo red. It's called avolino-dystrophy mostly because the initial population that was described was coming from a region of Italy called Avellino. In Boston, we actually have a pretty large population of patients from that area, so we see this not infrequently. So basically, we've found out that in this specimen, we can say that there is granular dystrophy type 2 or Avellino dystrophy, but the question is now, well, what was the surgical procedure that was done? And often just looking at corneas, you can figure out very many things about what surgical procedures have been done. Let's take a brief review of some surgical procedures of the cornea. There are so many of them, and it can be really helpful to be familiar with them. There is penetrating keratoplasties, or PKs, deep anterior lamellar keratoplasties, or DALK, Decimase stripping automated endothelial keratoplasty, or DSEK, Decimate membrane endothelial keratoplasty, which is a DMEK, and decimetorexis without endothelial keratoplasty. I put stars here because this is not really a corneal transplant. Here, tissue is removed in the same way, but nothing is added. That's a DWEK. And then we have Boston K-Pros type 1 and type 2. It's useful to be familiar with abbreviations because in ophthalmology notes, often you'll see just the abbreviations for these procedures. So looking specifically at these procedures, a penetrating keratoplasty is when you make a full thickness cut in the cornea, you remove a full thickness segment of cornea and put a new piece in. Deep anterior lamellar keratoplasty, you are scraping off Decimase membrane and endothelial cells. Deep anterior lamellar keratoplasties, you are removing the epithelium, Bowman's layer, and most of the stroma, leaving behind Decimase and endothelial cells, and you're replacing just that anterior aspect. DSEK, you are removing the endothelium and Decimase and replacing it with some stroma, endothelium, and Decimase. So you're actually adding a little thickness to the cornea. And DMEK, you similarly remove endothelium and Decimase, and you add only endothelium and Decimase back. And then we have the K-Pros, type 1 and type 2. With both of these K-Pros, you're basically making a full thickness corneal incision, just like a penetrating keratoplasty. You're adding back a full thickness cornea, but also hardware that's composed of both plastic and metal. So let's look at these in a little bit more detail. Here's a penetrating keratoplasty. Intraoperatively, a trephine will be used to make an incision, and then a whole entire segment of the cornea, usually a round shape, is excised. New cornea is placed and then sutured into position. The sutures can induce astigmatism. Over time, people will remove sutures to try to help with that, but there will also always be some weakness, and patients need to stay on eye drops to prevent rejection of the transplanted cornea long term. Penetrating keratoplasties can be done for many things. Here, for example, is a cornea where there was a penetrating keratoplasty. You can see epithelium, Bowman's, stroma, Decimase, and endothelium. Here you can note that the corneal stroma looks a little thin, and that in Bowman's layer there are breaks. When we see breaks like this or discontinuities, it is a sign that the patient might have keratoconus. Usually when we're seeing this, it's because a patient has keratoconus. Penetrating keratoplasties can be also done for infections of different kinds. This is a penetrating keratoplasty that was done for an acanthamoeba infection. Acanthamoeba can be very hard to clear with eye drops. Often it's eye drops like PHMB and chlorhexidine that are used. In the cornea, GMS is often very useful in highlighting the acanthamoeba cysts. Penetrating keratoplasties can fail, and so some patients can undergo repeat penetrating keratoplasty. So here was a repeat penetrating keratoplasty that was done for graft failure. And there's a few things that you can see here. First of all, the corneal stroma lacks many of those clefts, so it's edematous. There's also this purplish material here that we'll zoom into, and that is calcium accumulating in Bowman's layer. Descemet's membrane is down at the bottom, and you can see that there's a thick band of tissue behind it, which is a retrocorneal fibrous membrane. So just zooming in a little closer, band keratopathy is calcium. It tends to accumulate in very sick and unhealthy corneas, and it can be very painful in some patients because the corneal epithelium can't grow well on the surface, and it can abrade and erode and cause abrasions that are very uncomfortable. On the posterior surface where you see Descemet's membrane, you can see that there are no corneal endothelial cells, and that's why that cornea is very edematous. In part, you have that retrocorneal fibrous membrane coating the whole entire posterior surface. When there's a lot of corneal pathology and there's been often repeat corneal transplants, sometimes you can't do a regular corneal transplants, and so that's where sometimes you will do a procedure like a keratoprosthesis. And so this is what a Boston keratoprosthesis type 1 looks like. You can see that here a penetrating keratoplasty was done, and then a corneal graft was inserted and sutured into place. But here in the center of the graft, they snapped in a plastic screw with a metal back plate and a locking ring to keep a little portal open for light to come through and for the patient to see. This is usually covered with a contact lens, and long term, the patient needs to be on lots of eye drops. These can fail. Sometimes there can be melts that will happen. So in the pathology lab, you may see as a gross specimen a K-Pro, and then associated with it many bits of cornea, because usually they're just peeled off of the implant before they're processed. This is a type 2 keratoprosthesis, so it's basically the same thing as a type 1, but instead of leaving the cornea clear, here the eyelid skin is drawn up over the cornea right to that surface of the implant. And this kind of situation is sometimes used when patients just have too dry of an ocular surface, too much scar on the surface, and the corneal transplant just can't survive without being fully covered. So once in a while, you may run into these. Let's go back to the other procedures. So a DSEC and a DMEC, they're very similar. In both, you strip with a hook. You use a hook to basically scrape off the native Descemet's membrane with the endothelial cells that are there. And then you add back tissue. With a DSEC, you're adding a thin strip of stroma, Descemet's and endothelium. With a DMEC, it's just the endothelium and Descemet's. It's a little harder to do a DMEC because it's floppier. The DSEC is a little bit more stiff. In both of these cases, that tissue is sort of slid in through a little incision into the anterior chamber of the eye, and then gently you tap on the eye to unroll and unfold the tissue so that it gets into position. You're really trying not to grab the tissues so that you don't disturb the endothelial cells that are so delicate that are being transplanted. And then for these grafts, what happens is that they are kept in place with an air bubble. An air bubble is injected, and the patient has to stay on their back for some time to really keep that graft in place until the endothelial cells start working and sucking out fluid and allowing that graft to stick. Now, when a DMEC or a DSEC is done, most of the time we get these kind of specimens. So this is basically strips of Descemet's membrane. And what I can appreciate here is that really there are no corneal endothelial cells, which makes sense if the cornea was edematous, that endothelial cells there weren't enough of them to keep it clear. The other thing that we're looking at here is to see if there are any bumps called guttae on the surface, and here there are no guttae. So this is likely Descemet's membrane from a patient who had bullous keratopathy, meaning corneal edema, in a situation where the endothelial cells failed. And that could have been just from older age, or it could have been from many previous procedures like cataract surgeries and other surgeries that had damaged the endothelium. Here is another example. DMECs, DSECs, and DWECs are often done in patients who have Fuchs endothelial corneal dystrophy. And so here we see that the Descemet's membrane is actually a little bit on the thicker side. there's depletion of the corneal endothelial cells, and there's also a lot of these bumps that are called guttae. And the guttae are like little plateau shapes or little like anvil shapes that protrude from Descemet's membrane. The reason we often use PAS on this specimen is because sometimes you will actually also get buried guttae. So this is also in Fuchs. So here with an H&E, you would have probably seen that it was just a thick Descemet's membrane, but PAS really brings out that there are guttae within the Descemet's membrane. Now, patients are nowadays undergoing sometimes repeated corneal transplants and repeated partial thickness corneal transplants, like many DSECs and DMECs over and over. And so sometimes you will start seeing these failed grafts. And so here, for example, is a failed DSEC graft. You can see that there's an edematous thin strip of corneal stroma. And then there's also highlighted with PAS, Descemet's membrane. But as you look at it, you can actually see that there are two thicknesses of Descemet's membrane. So as we zoom in a little closer, you have a thicker Descemet's membrane that has actually a few guttae here and there on it. And you have a thinner Descemet's membrane with a little retrocorneal fibrous membrane behind it. Now the thick Descemet's is from the native cornea of the patient. And what happened probably is when they had the initial transplant, when Descemet's was being stripped off with a hook, probably not all of the pieces came off, because it can be really hard to tell if every little bit of it came off. Then you have your DSEC graft with a thinner Descemet's membrane. And then as that failed, there is some tissue growth on the posterior aspect. Here is someone who's undergoing a penetrating keratoplasty after a failed DSEC. And so you can see that there's a split here in the posterior cornea where that DSEC graft was being attached. And just zooming in, you can see corneal epithelium. Bowman's is here. There are some anterior stromal scars. I'm not sure why in this particular case, but then you see also the edematous graft, the Descemet's membrane of the graft, and then also some of that residual thicker native Descemet's membrane from the patient. We'll move on to deep anterior lamellar keratoplasty. So deep anterior lamellar keratoplasty, or DALK, what we're trying to do is preserve the Descemet's and endothelium of the patient because they may still be functioning well, and just remove the epithelium, Bowman's, and the anterior stroma. Often these are done in cases like keratoconus or someone who has a lot of scars in the anterior cornea, but may still have a good number of their own endothelial cells. And here what's done is an incision is made in the cornea, and then a cannula is inserted partial thickness into the cornea, and air is injected. And with pretty high pressure. So air is injected throughout the whole cornea, and it's supposed to basically dissect through the cornea to then allow you to excise just that anterior portion. Sometimes it doesn't work and a bubble will burst through, where you may need to convert to a full thickness penetrating keratoplasty. But from these kind of specimens, you get air bubbles from DALK procedures that are scattered throughout the cornea. And so in our patient, we had this specific situation where there were air bubbles from the DALK procedure. I wanted to touch upon a few other procedures that are relevant and you may see in corneas. There are many refractive procedures that are done or have been done in the past. I'm not going to look at all of them with you, but just things you should be aware of. Radial keratotomy is a procedure that used to be done in the past to correct astigmatism or change prescription. LASIK, where a flap is lifted and the cornea is reshaped. Photorefractive keratectomy, or PRK, where a portion of the cornea is shaved off to basically change the prescription. Superficial keratectomy, same idea as a PRK, but sometimes this is done. This can be done also to eliminate scars. And then we also have a procedure called corneal cross-linking, which is being done to stabilize corneas that are changing shape too much so that they stop changing shape, for example, in patients with keratoconus. Here is an example of radial keratotomy. These were basically big incisions that were made about 70 or 80% of the thickness through the cornea, and depending on the length and the depth of these incisions, it would alter the corneal curvature to a certain degree. This was done quite a bit in the past, but really now we don't do it anymore. And part is because initially you'd get a good correction, but then down the road, the prescription would start shifting and the cornea would be unstable. So not something that we do nowadays. But these corneas sometimes are removed when patients need a procedure. And so here it was a penetrating keratoplasty in a patient who had corneal edema. And you can see that there's evidence of a prior radial keratotomy. So all those black arrows are pointing to incisions that were made decades before in the cornea. You can see that the epithelium is intact over these incisions, but you can see that there's breaks in Bowman's and you have these incisions in the stroma. They go very deep in the stroma. Because there was edema here, you can see the Descemet's membrane is here, but no endothelial cells. So this really highlights the fact that when you make incisions in the cornea, they never really heal great, and there never really is great strength. So even when patients have had corneal surgeries or procedures, even decades ago, there are weak points that can reopen in situations like trauma. Here is a diagram just illustrating LASIK. In LASIK, we basically make an incision in the anterior aspect of the cornea through the epithelium and the superficial stroma. That flap is folded back. Laser is used to shave down and reshape the cornea, and then the flap is put back on. We can see these when in different specimens. Here, this is from an eye that was actually enucleated for uveal melanoma. There's a few things that you can see here. In this outer aspect, there's a faint line, and that's actually a corneal incision scar from prior cataract surgery. You can see here that there are some cataractus lens remnants here. Sometimes when there's these cataractus lens remnants that go all around an intraocular lens implant, it forms a white ring, which is called a summering ring. But this is not a normal lens, it's one that's been operated on. And then here you can see that there is an incision in the anterior corneal stroma that goes all the way across, and a very uniform thickness flap of anterior corneal stroma and epithelium. This is the LASIK flap. Just zooming in a little closer so that you can really appreciate that LASIK flap, and then the scar from the prior cataract surgery. Sometimes there can be infections that might develop also under a LASIK flap. Just something to be aware of. And then this is just PAS stain highlighting both Descemet's membrane, and you can see it's useful also in the eye in highlighting lens capsule, but not Bowman's layer. And just another couple examples here. Corneas can have evidence often of multiple prior procedures. So here we can see it looks like this cornea has had prior LASIK, and as it's been removed, there's been big separation. We also see that DALK kind of air bubble artifact. But what I want you to pay attention to is actually there is still Descemet's membrane here and corneal endothelial cells. So from this specimen, we can see that this is a cornea that had a history of LASIK, that then underwent an attempted DALK procedure, and it was converted to a penetrating keratoplasty. If it was a successful DALK, we would not be seeing Descemet's or endothelial cells. Another couple similar examples. Here is someone who had a superficial keratectomy, an anterior stromal keratoplasty, where you can see there's no more Bowman's layer. Bowman's layer does not regenerate if things have been scraped or excised from the anterior surface of the cornea. The epithelium is somewhat attenuated over it, and then we have absent Descemet's and corneal endothelium. So this is from an aborted DSEC that was converted to a penetrating keratoplasty, but the patient previously also had anterior stromal keratoplasty. Just another failed DSEC. Here I want, you can see both the edematous corneal stroma and the DSEC graft. And then you can see at the edge there's some stromal downgrowth that's growing onto the posterior surface of the cornea. Stroma can grow down through full thickness corneal wounds. So even if you have an eye trauma that was repaired, you can see that here's the scar, and then if it's not repaired just perfectly, and that's very hard to do, stroma can grow down. It can coat the posterior aspect of the cornea and can result in edema and failure. Epithelial downgrowth can sometimes happen from the epithelial surface as well. Epithelial downgrowth is often a disastrous situation for the eye. In this particular cornea, there's actually also an infection. You can see it hypopian in the anterior chamber, some iris remnants. Descemet's membrane is here, but there's epithelium growing down along a wound. Here is epithelial downgrowth from the ocular surface lining Descemet's membrane and also coating the anterior surface of the iris. Really, epithelial downgrowth is disaster for the eye. It's extremely hard to get rid of. Sometimes people will try to laser it off or do other procedures, but it can be really devastating, especially if it blocks the outflow tract in the eye. Corneal ulcers we'll see quite frequently with penetrating keratoplasties. You can see here inflammation, absent epithelium, melting of the stroma. Here you can see also that there's a hypopion. Hypopion is basically pus in the anterior chamber, and some of the iris came with this specimen as well. Last but not least, with corneas, I just wanted to show you something interesting. Once in a while, we will get also specimens that have corneal tattoos. Not very commonly done, but you'll see it once in a while. This is basically done to make a cornea look more dark where there's a white scar. The target is to get the pigment into midstromal depth, but here is a cornea that was excised, and you can see that this pigment is actually at all different layers. And what you can see here, here's epithelium. Bowman's is absent. There's a lot of stromal scar throughout. There's actually some purple calcium deposited, which we would see as white externally in the eye. And there's needle tracks here where tattoo ink was being deposited, but you can see some of it actually has gotten quite deep and is right up against Descemet's membrane. So all the way to Descemet's membrane. There's also a retrocorneal fibrous membrane here. And also in areas there is evidence of stromal neovascularization, and corneas that are quite unhealthy often will have blood vessels grow in. That's stromal neovascularization. So more neovascularization here, calcium, tattoo ink. So in summary, our first case was a DULC in granular dystrophy type 2. And now we'll move on to our second case here. And this one is a case with an eyelid lesion. Eyelid lesions, often you will get them chopped up in many little bits, and they'll come in bits and pieces. So sometimes they can be a little hard to figure out. Sometimes it's nice, you will get the whole entire lesion as one big specimen, which makes it easier for orientation. So we'll start with this one first, looking at an example of this particular lesion where you have many different chopped up pieces of the tissue. And then we have that same lesion actually from a different patient that came out in one piece. So let's take a look at the pieces we have. So one thing we can see is that there's lacrimal gland tissue, there are sebaceous glands, and there's fibrous tissue. So when I see this, to me, this means that we're in the tarsus because there's fibrous tissue and sebaceous glands, which in the tarsus are called meibomian glands. Lacrimal gland tissue points to me that we're at the superior aspect of the tarsus if it's an upper lid tarsus. And then here should be conjunctiva, which looks like it was abraded. Again, if this is, again, coming from the tarsus, these are called the accessory lacrimal glands of Wolfram. And just to show you, in the eye, there is the main lacrimal gland, which has an orbital and palpebral lobe, but there are also accessory lacrimal glands. There are accessory glands of Wolfram, which are found at the superior aspect of the tarsal plate, or in the inferior lid, it would be at the inferior aspect. And then there are the accessory lacrimal glands of Krauss, which are found in the conjunctival fornices. Sebaceous glands in the eyelid are meibomian glands. And then here we can start seeing a little bit of a cyst lining appearing. And now you can see more cyst with some keratin material here. You can see that this keratin is somewhat pink and stringy, not short little bits. And that there's also, as we look at the actual cyst lining, lack of keratohyalin granules. It sort of has this corrugated appearance and a very regimented basal layer. And for us, when we see this in eye pathology, this is basically diagnostic of something called an intratarsal keratinous cyst. So let's try to make a little bit more sense of it by looking at some normal eyelid histology to orient us. So eyelids, clinically, we often talk about anterior lamella and posterior lamella. And sometimes a surgeon may ask you, is the lesion, was it in the anterior lamella, in the posterior lamella, is the basal cell, which area is it in? Because from a reconstruction standpoint or a clinical standpoint, it can sometimes make a difference. The anterior lamella is skin and orbicularis muscle. The posterior lamella is tarsus, this tarsal plate, and the conjunctiva. And as we zoom in a little bit closer to the eyelid margin, we have skin. Here's our orbicularis muscle. There are eyelashes. There are some sebaceous glands that are present at the bases of lashes that we call in ophthalmology the glands of Zeiss. There are also often apocrine glands here that are called the glands of Mole. These often give rise to hydrocystomas. There's also a little slip of orbicularis muscle that's separated from the rest. And this we call the muscle of Rheolon. And it's right at the mucocutaneous junction, right below it. And clinically, it gives us this appearance called the gray line. Often an eyelid is split along the gray line for surgical procedures that separate those two. Then we have the tarsus with the meibomian glands and conjunctiva. Again, just zooming in, mucocutaneous junction, muscle of Rheolon, meibomian gland, conjunctiva, skin, Zeiss glands, glands of Mole, your eyelashes. And the reason I'm showing you here another eyelid is because here is anterior lamella, posterior lamella, and here this one actually has an accessory gland, a lacrimal gland of Wolfram right there in the tarsus. You won't see it on every section, but you do see it from time to time when you have a full thickness eyelid that's the whole entire height of the tarsus. And I'm going to just show us an example of the same lesion that we just saw, the intratarsal keratinous cyst, but when there was a full thickness eyelid excision that was done to remove it. Here we can see the cyst, and here in this section is a little anterior to the rest of the tarsal plate, in part because sometimes they pouch out, they arise from the tarsus and then pooch out. And you can see that there's a meibomian gland along the whole length of the tarsal plate with a dilated duct. It's just showing you a little bit more closely some of that. It's a beautiful kind of architecture of the meibomian gland. And here's the conjunctiva underneath. And the meibomian glands, just as a reminder, there's a lot of them. There's tons of sebaceous glands, and that's why we get things like sebaceous carcinoma with quite a large frequency in the eye area. And they are really long tubes that are the whole entire length of the upper lid and the whole entire length of the lower lid. Here is an example from that same specimen, but just a deeper level. And you can see here's a meibomian gland, the meibomian gland duct, and you can see the cyst, actually the cyst lining arising from that meibomian gland duct. Again, it has that intratarsal keratinous cyst, that typical kind of appearance. The other thing I wanted to point out here is that as glands get blocked, sometimes material backs up and you start getting chalasia or styes. And as you zoom in, you can see that there's some lipid dropout, and also here you see some giant cells, a chalasian is when you get some lipogranulomatous inflammation in the tarsal plate. The other thing I wanted to point out in this particular eyelid was this incidental finding. You see some pigment here. And so as we zoom in, it looks actually very similar to what we saw in one of our corneas. This is incidental eyeliner tattoo. We see that in eyelid specimens. For example, here's a basal cell, and right next to it is eyeliner tattoo. And so intratarsal keratinous cysts, why should we care? Does it matter? Or should only our late Dr. Jacobiak, who would like to call himself the king of eyelid cysts, care about it? Well, the reasons that we should matter is patients who have intratarsal keratinous cysts can actually have Gorlin syndrome or nevoid basal cell carcinoma syndrome, and that's important to know if it's not yet been diagnosed. Not all of them have it, but some. And then if it is an intratarsal keratinous cyst, the whole thing should be excised to prevent recurrence. And then clinically, there is a differential diagnosis for these cysts where something else may have been suspected. So Gorlin syndrome, autosomal dominant process with a mutation in the patch gene. There are many different findings, including things like odontogenic keratocysts, calcified falx cerebri, bifid ribs. Here is an intratarsal keratinous cyst. And just comparing it side by side from the same patient with an odontogenic keratocyst, you can see that there's some similarity in the cyst lining. These patients will have these palmar and plantar pits that someone can look for in the clinic if they've had one who has an eyelid lesion. And then this is what these intratarsal keratinous cysts look like clinically. If you flip the lid, in a young patient who has Gorlin syndrome, you can see often several of these cysts. If you have an older patient with just a single cyst, it is more likely to be a sporadic one. Differential diagnosis, other things that arise from the tarsal plate. You could have chalasia, which is an inflammatory process, but sometimes the inflammation settles and it looks more like a nodule. A chalazion is more of a lipogranulomatous type inflammation, so this is more typical of what we see with that. We sometimes will also get little nodules that are localized amyloid that look yellow and have some resemblance. Sebaceous carcinoma can also look similar. Here is a patient who had a sebaceous carcinoma that was thought to be a chalazion that was excised, found to be a sebaceous carcinoma. That's why we tell our residents to always send all chalasia that they excise. Once in a while, you get a surprise of a sebaceous carcinoma. Here's a sebaceous carcinoma from another patient. And sebaceous carcinomas will arise from the meibomian glands. Here you can see carcinoma in the meibomian gland and also causing dilation of the ducts. This is sort of a beautiful example where it's really filling up all of the meibomian gland. And just at a higher magnification, you can see the vacuolization and many mitoses here. Sometimes things like injected triamcinolone, which is a steroid, can give you a little yellow nodule. This is what it can look like histopathologically, triamcinolone. And these are used sometimes for eyelid lesions, but like in this particular case, it was cut out because it was thought it might be a chalazion or some other skin lesion. And then I just want to remind you, eyelid-wise, there can be many foreign materials that can be found in eyelid specimens. People inject things and have procedures all the time. Silicone is quite common. That's what it looks like. Hyaluronic acid is found very frequently. There can be facial fillers that have other materials in them, like this one here had acrylic particles, and this one had nodules that ended up being porcine collagen. So with that, just as a summary of our case 2, we saw that there was an intratarsal keratinous cyst, which is pretty unique to the eyelid, should trigger thoughts of Gorlin syndrome if it is not a sporadic case. And I'd like to move on to our third case, which is our last one that we'll be covering. And this is a blind painful eye. So in eye pathology, we'll often get blind painful eyes. They usually don't look like normal eyeballs. We'll scroll through a few screenshots of what this blind painful eye looked like before delving in. So you can see these are the pieces just that we'll be zooming in on. And then there's some other material that was here as well as part of that blind painful eye. So before we delve in, let's review some normal eye histology. We already looked closely at the cornea. You have the anterior chamber behind the cornea. The angle is where that iris joins with the cornea. This is the iris, the ciliary body, and we have a lens. Again, taking a look closer at the angle structures, there's the trabecular meshwork and Schlemm's canal, where aqueous fluid drains out of the eye. Your ciliary body here. There's the Schlemm's canal and trabecular meshwork. This is the iris. The iris has dilator and sphincter muscles in it. This is the iris pigment epithelium, ciliary, and it continues on to the ciliary body. The ciliary body has a folded area called the pars plicata. Zonules extend from this to support the lens. You usually never see them in histopathologic specimens. And then you have also the ciliary muscle and the flat part of the ciliary body, which is called the pars plana. The epithelium over the ciliary body converts to a pigmented and a non-pigmented layer, and then it continues on to turn into the retina. As we look at the retina, there's a vitreous cavity, and then the retina has many layers. You have the internal limiting membrane, ganglion cell layer, inner plexiform layer, inner nuclear layer, outer plexiform, outer nuclear layer. The outer nuclear layer is where your photoreceptor cells are. You have your photoreceptor inner and outer segments. The inner segments, you can sometimes make out the rod and the cone shapes. And then you have retinal pigment epithelium that basically chews up little bits of the photoreceptors every day and helps recycle the visual pigments. Bruch's membrane is underneath. Then choroid, which is where your vascular supply is, and after that, the sclera. In the peripheral retinal, you'll have very few ganglion cells. When you get towards the macula, you'll have multi-layered ganglion cell layers. And then you can ignore the tumor that's up here, but this is just to show you optic nerve. You have your sclera, where the optic nerve pierces through the sclera, that's called the lamina cribrosa. You have your subarachnoid space around the optic nerve, and then you have here a central retinal artery and vein. All right, so returning to our actual case, as we pan in, we can actually find that there is a cornea. It is a very edematous cornea. You can see there's some epithelium. There's Descemet's membrane. The Descemet's membrane has actually separated from the rest of the cornea because it was really adherent to other fibrous tissue. There's remnants of ciliary body and a cyclitic membrane and remnants of an iris. So here, corneal epithelium, Bowman's layer, edematous corneal stroma. Zooming in towards the posterior aspect of it, there's some corneal stromal neovascularization. Descemet's membrane here, a retrocorneal fibrous membrane that's actually causing some adhesions to the iris. So those are called anterior synechiae. And then on the, this is iris here. You can recognize it's iris because it has these thick-walled vessels. That's very typical for iris. There's also some inflammation here. And then on the posterior aspect of the iris, there's a fibrovascular cyclitic membrane. Here again, you can see that there's the retrocorneal fibrous membrane, which is attaching Descemet's to the iris, the fibrovascular cyclitic membrane that's arising sort of from the ciliary body and the iris, and quite a bit of inflammation, which is why blind painful eyes are often painful because of inflammation. There's just more of the same. And then just the ciliary muscle is quite atrophic compared to normal. Here's the remnants of the pars plicata. Here's more of the cyclitic membrane. As we look in other areas, we see sclera, and then we see this kind of oval here with some foreign material. So this is actually what silicone scleral buccal band looks like. We'll go through that in a second. And then in a few places, we see very residual little bits of retina, but mostly fibrous tissue, Bruch's membrane, remnant of choroid, really not much at all, and you have sclera. So this is really a Tysical eye that's really shrinking and really lacks many of the normal structures. As we pan around, there's also some foreign material that we can see here in several areas that looks like it's embedded in the sclera. This foreign material has this kind of typical honeycomb shape, and also a few areas of calcification next to the foreign material. Here's a few remnants of retina or neural kind of cells. A few more remnants. You really can't, don't have much detail. There's no photoreceptor outer segments here anymore. And this again looks like it's remnants of retina again. So I wanted to delve into for a second retinal detachment repairs. Often when there's a retinal detachment, you can have exudate that's under the retina that you can appreciate in some eyes. And retinal detachments can happen if there's a tear in the retina, and they're repaired in a few different ways. One way is something called a scleral buckle. The other way is a vitrectomy, where all the vitreous gel is removed, laser is applied around the tear, and then the eye is filled with material like air or silicone oil to hold the retina in place. Silicone buckle, scleral buckles, on the other hand, go around the eyeball and basically squash the eyeball to allow the retina to reattach to where the choroid and the sclera are. So it squashes the eyeball to allow that reattachment to happen. So in our specimen here, we saw a silicone scleral buckle. And then the other thing I wanted to touch upon is hydrogel scleral buckles. There's a specific kind of hydrogel scleral buckle that was implanted in the 1990s. I'm not going to mention the name because of CME things, but it was many of the company was in the Northeast, and then the buckle was taken off the market and no longer used because what happened is that the implant would expand, and this could be years and decades after implantation, and start squeezing the eyeball, eroding into the eyeball. So even to this day, we are removing them on a pretty regular basis when patients are coming in. So no longer on the market, but we definitely see these in specimens. And so what happens is you can see the scleral bucklet expands, and on radiographically it has a very typical appearance. Often when it expands, it's really squashing the eyeball. Here with
Dr.
an MRI.
Wolkow?
Yep.
Sorry to interrupt. We're about 10 minutes till the top of the hour.
Okay, great. Thank you.
Thanks.
We'll wrap things up. So this scleral buckle is squashing the eye. Sometimes it can look like a mass, or it can be hard to remove because it can even cause rupture of the eyeball as you try to remove it. Here it looked like a mass. And intraoperatively, when we try to remove it, here you can see, and this is the same patient, both photos, it's this expanded jelly-like material, and here behind some of the jelly-like material, there was both the hydrogel and a silicone buckle. When you remove it grossly, this is what it looks like. And then histopathologically, it has a very typical appearance, like sheets of this honeycomb kind of lattice. And sometimes it's more crisp, other times it's more hazy. And this is basically what it looks like. It stains very strongly with Alcian blue. And so you can see it embedded in bits of sclera, like in our patient. And so here you have more bits of it. So this in our patient was all a hydrogel scleral buckle. So in summary, our case 3 was a tricycle eye with a cyclitic membrane, evidence of prior retinal detachment with both silicone and hydrogel buckles. And the last thing I just wanted to touch on for 2 minutes before we jump to questions is silicone oil that's used for retinal detachments. It can spread into many tissues, including outside of the eye when it's injected in the eye, and we often see it histopathologically. So here's a place where there was a retinal detachment and silicone was used, and you can see silicone oils, this bubble artifact in the retina, more of this bubble artifact with associated inflammation. Here again, bubble artifact in the retina. This is all silicone oil. Here in fibrous tissue that's in the angle of the eye. So this is iris here, ciliary body, and here in fibrous tissue, there's some silicone oil. It can even get into the optic nerve. So here, this is retina up here, optic nerve. You can see it gets into the retrolaminar optic nerve behind the lamina cribrosa. And in this particular case, it even got into that subarachnoid space where there's silicone oil. I'm not quite sure how it got into that space, but there's also a granulomatous reaction to the silicone oil. Even it can travel into the skin. So this was injected in the eye, but it ended up in blepharoplasty specimens from a patient who had a previous retinal detachment repair. So in summary, we've reviewed a few cases, a cornea case, an eyelid case, and an eyeball case, and some relevant anatomy and histology today. With that, I just want to show you some references, and I appreciate your time. If you have any questions, be happy to answer questions as they may come along.
Thank you so much. At this time, we're going to move into the Q&A. You can submit your questions via the chat box, or you can unmute to ask a question. If you're submitting via the chat, please ensure the message goes to everyone so that both the presenters and attendees are able to see your questions. And to unmute, select the microphone in the lower left corner. And once you've asked your question, please remute. So please go ahead and ask questions. You know, I do have one question. If you could only teach one disease from your presentation to medical students, which one would it be?
Gosh, that is a really hard question.
I can give you two.
Yeah. I mean, medical students that are rotating through an ophthalmology rotation, they will definitely see Fuchs endothelial dystrophy, and that is a very common disease.
Okay.
I'd say that, yeah, neuropathologists looking at eye pathology specimen may very well get a Fuchs case. And so knowing about the Goutte, and yeah, that would be very useful.
Awesome. And someone is asking, a great class. Thank you so much for the great talk. And someone's asking, please show references again.
Okay, so for these references, so there's some references throughout the talk, but reference-wise, there's also 3 books that I think are extremely useful there and that I refer to. There's a beautiful eye pathology book by Ralph Eagle, and then actually American Academy of Ophthalmology puts out a book series every year and updates it on a yearly basis, and it has an eye pathology section.
I've actually bought a couple of those American Academy of Ophthalmology for teaching purposes. They are pricey, but they are very good.
They are very good, and they work very hard in keeping them updated every year. So yeah, it's really a great resource that covers many of the basics and even beyond. Yeah.
Yeah, it's great. Then you're getting more perfect thanks from person asking for the references.
All right. Well, if there are no additional questions, thank you again for joining today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation. Completion helps ensure accurate reporting to the accreditation board. A link to the evaluation will appear on your PathLMS screen upon the conclusion of the Zoom meeting, or you can navigate back to the main course and select the evaluation option. Once you've completed the evaluation and selected your credit amount, please then select the appropriate certificate based on your credentials. The PowerPoint slides will be posted to the AANP website in the next week. The recording will first be posted to PathLMS for 30 days, and registrants may claim CME credit during that time. After 30 days, once the credit claiming window closes, the recording will be posted to YouTube. Thank you again to Dr. Wolkow for an excellent presentation. This concludes the session for today.
Bye, everybody.
Okay. Thank you for having me. It was a pleasure to join you all today.
Thank you.